Hi there, my name is Liza Smith and I'm one of the assistant professors of emergency medicine at Baystate Medical Center, where I'm also the clerkship director, and I'm super excited to be here with you guys today virtually at the Controversies and Consensus Conference. I've got no disclosures other than to say I have not had a haircut since January and a very large latte this morning, so I'm likely to talk very quickly. Bear with me. So I'm going to talk to you today about aortic dissections, which is a topic that I have been fascinated by for as long as I've been studying medicine. As you probably know, back in 2015, ASAP released a clinical policy on the evaluation and management of aortic dissections in the emergency department, so all of your burning questions were answered. What could I possibly be talking to you about today? So it turns out there's been some important literature updates since 2015 that I want to go over with you. One in particular that I think is super important to know about. And in order for you guys to really understand the context of it, I've got to go back in time and cover some of the old stuff too. So bear with me. Aortic dissections are kind of the stuff of emergency medicine nightmares, right? They're rare things whose presentation looks like a lot of other really more common things, and missed or delayed diagnosis has some really real morbidity and mortality outcomes for our patients. One of the things that makes aortic dissections particularly tricky is that to effectively find them and or rule them out, so to speak, you really have to be getting a CTA of the chest, abdomen, and pelvis in your patient. So the wish for a long time for many of us has been for there to be a way for us to reasonably select patients in whom we're considering aortic dissections who are low risk enough for us to exclude that diagnosis without having to give them a huge contrast dye load and irradiate their entire torso. So what we're going to talk about today is some of the approaches that people have tried to answer that very wish. So the first approach that we're going to talk about is risk stratification, identifying patients who can be considered low, medium, or high risk for having a dissection based on historical and exam findings. So a few years before the ASAP clinical policy, the American Heart Association and the American College of Cardiology put out their own clinical policy and guidelines where they identified 12 clinical markers based on history and physical exam that were associated with aortic dissection. So in 2011, Rogers et al. Used a retrospective data from the International Registry of Acute Aortic Dissection, the IRAD, to validate those 12 clinical markers. So what they did is they separated the 12 markers into 3 categories and came up with what they call the Aortic Dissection Detection Risk Score. Spoiler alert, I'm going to say that many, many times over the next 15 minutes, and I'm going to flub it. So those of you following at home, if you want to get your drinks out, this could be fun. So they separated it into 3 different categories. One, sort of the epidemiological predisposing conditions, pain features, or sort of how the descriptors of the pain were described by the patient, and then physical exam findings. And these were meant to be applied to patients who clinicians suspected aortic dissection because they presented with either chest, back, or abdominal pain, syncope, or symptoms consistent with a perfusion deficit. The way this score works is that a positive finding in any one of those columns gets you a point. More than one in a single column still just gets you 1 point. So the scores can range anywhere from 0 to a maximum of 3. So they looked in that IRAD database and they applied this score to 2,538 patients with aortic dissections. They were able to separate them into low risk, which they defined as having an aortic dissection detection score of 0, intermediate risk, or score of 1, and high risk, which was 2 or greater. They found that 95.7% of patients had a score of at least 1, so 1, 2, or 3 on that score. And so from that, they decided that this risk score was a very sensitive clinical tool for the detection of acute aortic dissection. It's not important that you can read what this clinical pathway is, but the next step that they did was they used that aortic dissection detection risk score to come up with an algorithmic approach risk stratification-wise for diagnostics. The important thing to know about this pathway is essentially unless you had a score of 0, you're getting advanced aortic imaging, so a CTA, chest, abdomen, pelvis. So if we look back at the score that they derived, you look at the things in all of those categories, and that's the reason that you're working them up for aortic dissection, right? It's not because somebody came with chest pain. We see that 10 times a day. It's because they came with chest pain and they're morphinoid, and they've got a focal neurodeficit. And so your illness script has already been triggered because this test is positive. So does it really help you for somebody else to say, yes, you should think about aortic dissection in those patients? You should also probably be completely terrified that 4% of dissections had a score of 0, because that's really scary. So are we really comfortable with the sensitivity of this score, and is it even clinically useful? ACEP didn't really think so either. So with a level C recommendation in those 2015 guidelines, they advise that you not attempt to identify very low risk patients using clinical decision rules alone. All right, the next approach. I think it's one that you're going to be very familiar with because it's the dDimer. So in 2009, Suzuki et al. Performed a prospective multicenter study approaching dDimer use using that same IRAD database and seeing whether or not there was a way to use the dDimer to exclude aortic dissection in lower risk patients. So it was a prospective study with centers across Europe, the US, and Japan. They enrolled 220 patients in whom dissection was suspected. They obtained a dDimer on all of them, and then those patients underwent clinical evaluation and management as per the primary team. 87 of those patients were found to have radiographically proven aortic dissection. The other 133 had something else. So maybe it was a PE, maybe it was an MI, and some of them just had other unspecified. Based on these findings, they determined that using a dDimer cutoff of 500 nanograms per milliliter, which is the same cutoff that you're already familiar with in the PE studies, gave a negative likelihood ratio for dissection of 0.07 if this tool was used within the first 24 hours of symptoms. They've determined, based on that the evidence is now sufficient to suggest that routine use of dDimer testing is helpful in risk stratifying patients with suspected acute aortic dissection. But if you look at this study, right, it was multi-center, so kudos to that, but they still only had 220 patients, which even in something as rare as dissection is a pretty small sample size. They also had a yield of 40%. So of the 220 patients that got enrolled, 40% of them had a dissection, which is bonkers high for risk. So it really raises a question about generalizability, right? How is this going to fare in a normal population of people where the average yield on CTs for dissection runs somewhere in the range of maybe 2 to 3% in some estimates? So is this really generalizable? Hard to say. ACEP also wasn't convinced. In those 2015 guidelines, they gave level C recommendations that providers should not rely on dDimer alone to exclude the diagnosis of aortic dissection. All right, so that was the background. Now we can fast forward to 2018 and the ADVISE trial, which is what I really wanted to talk to you about. So working off the foundation of the prior studies that we just talked about, the ADVISE team designed and tested an aortic dissection detection risk score and dDimer clinical pathway for ruling out acute aortic dissection. So it's combining clinical risk stratification with a dDimer biomarker. You see what they did there? Yeah, so this is also an international multi-center prospective observational study. They enrolled 1,850 consecutive patients with the same inclusion criteria as for that original Rogers aortic dissection detection risk score paper, and 6 hospitals, 4 countries, 2 years. They calculated the aortic dissection detection risk score for all of these patients. They obtained a dDimer in all of these patients, and then all of them got either diagnostic imaging, autopsy, surgery, or 14-day follow-up. So of those 1,850 patients, they found that about a quarter of them had an aortic dissection detection risk score of 0, a little over half of them had a score of 1, and about 20% of them had a score of 2 or greater. As you might not be shocked by, the dDimer positivity increased as the aortic dissection detection risk score increased, but 8 patients had a negative dDimer and a dissection, and 3 patients had a negative dDimer and what was considered a low risk aortic dissection detection risk score. So 241 patients, and the score would have missed 3 of them. So based on their working with the numbers, they determined that an aortic dissection detection risk score of 0, very sensitive, not very specific. A score of 2, you lose some sensitivity, specificity is okay. But if you go with a 1, you get that sensitivity, you don't sacrifice as much of the specificity, and isn't that the Goldilocks zone we want to be in? So they determined that aortic dissection detection risk score of 1 or 0 and a negative dDimer effectively excluded acute aortic syndrome or aortic dissection. This was official enough that MD Calc created a calculator for it, widely available on the internet. So this is out there in the world. But before you go getting too excited, we need to remember that the two components of this risk pathway, when studied individually, were pretty problematic. This is also based on an observational study, which means there's a lot of confounders. The physicians determined who to include, and they weren't blinded to the pretest probability assessment. Half the patients didn't get definitive imaging. They got follow-up in 14 days, and is that really sufficient to exclude dissection? And in this study, they had a 13% rate of aortic dissection in their population, which again is significantly higher than the estimated yield of CTAs in the general population, which is somewhere around 2 to 3%. So it's not clear how this tool will fare in a population with a lower risk or a lower prevalence, but it's pretty exciting that this is out there. So I wanted you to know about it, both because I think this is sort of the wish and the dream that we've looked for so long. I don't think it's ready yet for prime time, but I want you to keep your ears out because I think there's going to be more to come on this in the coming years. Thank you so much for having me.
Thank you. That was just a great review of the evidence. Can I ask you one quick follow-up question? Are you using dDimer in your practice at all? Like, is there even a subset population? Nobody.
I want this to be true very badly, and I am eagerly awaiting that external validation because we've seen plenty of risk scores. You know, San Francisco syncope rules come to mind that looked really, really promising, and we wanted them to be true, and they completely floundered in the general population. So I am hopeful, but cautious, and I'm not yet using a dDimer or an aortic dissection detection risk score. You just wanted to hear me say it one last time in my current practice.
Thank you so much for that talk.
Thank you.